Good morning, everyone. Thanks for joining. Thanks for your time being here. I understand we have a number of people from around the world, so that's very exciting. This talk with CyberSight is going to be on models for MIGS. It's really about using simulation models to prepare surgeons for their first MIGS cases. There have been a number of other discussions, webinars on CyberSight, which I would encourage you to check out about MIGS. We're going to be doing a lot more than just models here because we need to get some background. So let's jump into this. My financial disclosure, I am the founder and president of Insight LLC. We make the Simuli ophthalmic surgical training models. We'll be showcasing those a lot here. So a little background about myself. I am a general ophthalmologist. I practice out of Beverly Hills, California. My focus is on cataract and refractive surgery. I am not a glaucoma surgeon. I don't consider myself a glaucoma surgeon, but as we'll see, MIGS is changing that. The reason I got into this whole thing with Simuli and the models is I did a one-year LASIK-only fellowship following my residency. It was great, but back then LASIK was really hot, and I just did LASIK for a year, and I found it a challenge to get back into intraocular surgery and cataract surgery, after only having residency skills and then being off for a year. So I had to find ways and develop ways to practice techniques like capsulorhexis and other things and practice them over and over, and I was able to rapidly improve my skills. And by sharing those techniques that we developed, fast forward now many years, we have now developed the Simuli line of ophthalmic surgical training models to help other surgeons really flatten that learning curve, and it's been valuable. We've seen it really improve resident training, and also for surgeons who are already out there practicing, when they want to try new techniques, it's not always that easy to get back in and jump into something new and different, and this makes it easier. So just a little quick polling question here, try to find out more about our audience. I currently perform some types of MIGS surgery either weekly, monthly, rarely, or never. So if you could just answer that, we'll get an idea of the audience here. We'll just wait for a moment for those results to come up. Okay, so we're at 27% rarely and 73% never. So really, we don't have a lot of MIGS surgeons here. So this is great. This is the perfect audience for this type of situation. That's great. So general ophthalmology and glaucoma surgery. Generally, we don't think of those two things as going hand in hand. General ophthalmologists don't want to deal with glaucoma surgery, the follow-up, the blood management, all that. In the words of Austin Powers, that sort of thing just ain't my bag. So that's really changing, though. In fact, glaucoma surgery with MIGS is within the scope of the general ophthalmologist. And in fact, you are the focus of many of these MIGS companies. They're looking for the general ophthalmologist, the people that are doing cataract surgery. That's who they want to target, because MIGS in combination with cataract surgery is an excellent way to treat glaucoma. So what is MIGS? I think we all have a pretty good understanding of it. It's an acronym. It stands for minimally invasive glaucoma surgery. And that stands in contradiction to our traditional glaucoma surgery, which is the trabs and shunts and tubes. Those are much more involved surgeries, and they require follow-up care and blood management. General ophthalmologists generally stay away from those because of the time commitment, and it's just especially that blood management. So MIGS is glaucoma surgery. The goal is to reduce intraocular pressure, to reduce or prevent damage to the optic nerve. We want to try to avoid the complications and the unpredictable nature of conventional glaucoma surgery. And of course, I'm referring to the conjunctiva and blood management. We want to preserve or avoid the conjunctiva as much as possible. MIGS gives us the advantage of a lot lower risk and lower maintenance, but also generally with lower efficacy. It's not for every patient. It's typically for the mild to moderate glaucoma patient. The main thing is we get to avoid that scary bleb. That one looks pretty scary. So let's talk about MIGS devices and the procedures. There are many ways to classify them. You can look at the anatomy in the eye where you're targeting. You can look at the approach, whether you're coming from an ab interno or an ab externo approach. You can look and see, is there an implant or is there no implant? Here's one way to kind of divide them into like the incisional or ablative groups versus the implant. So under that incisional ablative side, we have goniotomy, which was really kind of the first MIGS procedure. We've got GAT, gonioscopy assisted transluminal trabeculoplasty. iTrack with LX, passing the catheter 360 degrees around the Schlemm's canal, seeing that blinking light. We have Omni. They also kind of pass a little device through the canal. And both of those devices, you have the ability to inject viscoelastic on the way back to kind of blow open the canal and open up the collector channels and kind of help that distal outflow. We have trabectome, which is removing the trabecular meshwork and also the Cahook dual blade, excising the meshwork. We have ECP, endocyclophotocoagulation. So all of those, I see those as kind of in that same category, whereas on the other side, we have the implant-based procedures, iStent, iStent inject, iStent supra in the suprachoroidal space, CyPass, which of course has been recalled, the Hydrus from Ivantis, the Zen with Allergan, the InFocus microshunt, and we have other things coming. There's the MiniJect, iDose is coming from Glaukos, and many others. It's an ever-changing landscape, ever evolving as we learn more, as we get better options. It's always changing. So the target of MIGS, most MIGS devices or procedures are designed to restore function to the conventional outflow system. That means going through Schlemm's canal. Some do target the unconventional outflow system, and you have to be familiar with your anatomy. So quick polling question again, my understanding of angle anatomy is excellent, just okay, or hey, what is the angle? So we'll wait a minute here for the questions to come up, the answers to come up. Okay, so we have 50% excellent and 50% just okay. Well, I'm glad nobody said what's the angle. That's fantastic. For those 50% that's excellent, that is great. The people that are just okay, you've got some work to do before jumping into MIGS. So we're going to help you do some of that right now. The key steps to preparing for MIGS, first we have to understand the anatomy of the anterior chamber angle, and that's what we're going to go into right now. We're going to get to these other points on this slide as we go along. So here's our angle anatomy. On the right-hand side of the screen, you can see our cornea here transitioning into sclera. Hope you can see my cursor. I think you can. Here's the iris plane coming in. Here's our trabecular meshwork. Here is our scleral spur. That is so important to understand how this sclera wraps around, forms the scleral spur. It's the support structure and housing of Schlemm's canal here, and then that goes on to the connective channel. So let's dive into these slides a little bit more. So here's Schwalbe's line. We know that's basically the termination of Descemet's membrane. It's not always visible. You can look and look. It's hard to see, but it's there. Here's our trabecular meshwork. I always have to find that. It's the mesh-like structure at the iris scleral junction of the anterior chamber. It filters the aqueous fluid into Schlemm's canal for the conventional outflow. Here's our scleral spur. It's that prominent white line. That's your main anatomic landmark. You find your spur, and above that is your meshwork. There's going to be other pigmentation up in here sometimes, which is false. That's not the meshwork way up there. You find your spur, you find your iris plane, follow it out to the scleral spur, find your meshwork, and that now you know where you are. Here's Schlemm's canal, which obviously we can't see with the gonioscopic view. It's located behind the trabecular meshwork. It's a circular canal that collects the aqueous humor from the anterior chamber and delivers it to the collector channels for conventional outflow. It's basically like a lymphatic vessel, and it takes that aqueous and filters it out. And then of course our collector channels, there's about 25 to 30 channels that accept the aqueous fluid from Schlemm's canal and pass it on to the aqueous veins. Here's a scanning electron micrograph view of the angle. For orientation, here's our cornea. Here's our trabecular meshwork. Schlemm's canal is in here, right behind the meshwork. Here's the ciliary muscle attachment, ciliary muscle here. Here's our suprachoroidal space. Obviously, this is cadaveric, so it's different. But this is where devices can slide down into this space here, and here, of course, is sclera through here. So very important to understand what's happening and where the anatomy is. Let's take a look at a bunch of these pictures, and what you're going to see is they're all different. The anatomy looks different, the pigmentation looks different, how well the angles open. You need to start looking at these angles in the clinic. You don't always have to do this in the operating room, but get yourself trained on the anatomy, and it's going to look different in the clinic versus in the OR. In the OR, your patient's pseudophakic. The angle's going to be much more open. You're going to blow it open with viscoelastic. You're going to see a lot more of the ciliary body band. So here we go. We're going to start from the iris. Don't come from top down, come from bottom up. Find your iris, find your ciliary body band, identify your scleral spur, then you can find your trabecular meshwork, and oh, there's Schwalbe's line, pretty faint. Again, another view of that in a different model. I think sometimes we get too focused in on the little details of which is the scleral spur, which white line is it, but if you pull back, if you pull your vision back and just look and see as a bigger picture, it becomes more obvious. Like look here, bam, right there, scleral spur, that white line. Same thing here, down there, scleral spur, not up here, okay, down here, iris plane, scleral spur, TM. Same thing here, very easy, scleral spur right here, not up here, okay? This is like sample Lisi's line, this is extra pigment up there. Here's our meshwork, we find it, follow the iris plane, scleral spur, TM. This is just another view, so orienting it to the anatomy of the eye, the curvatures, iris plane, scleral spur, meshwork, Schwalbe's line. Iris plane, scleral spur, meshwork, Schwalbe's line. Again, iris, scleral spur. I don't want to belabor this point too much, but you can't overstudy, you can't overlook at these enough to be comfortable going into surgery. Last thing you want to do is get into surgery and not know where you are and where you're going to put your device or where you're going to ablate. Okay, I think we've beat this to death here. So again, iris, much more open, you know, viscoelastic. You're going to see the concavity of the iris here. Very good view. Look how concave that iris is. Look how deep it is. Here's some ciliary body band, scleral spur, meshwork. So angle anatomy, intraoperative tips. You can look for blood in Schlemm's canal. It's like a beacon in the night. We're going to show a picture of that, actually a video. I never enter the eye with my MIGS device until I can see the target. I have to, you know, have the patient in the position, have the gonio prism on, identify the target, know where you're going to go, get a good view, and then you go. Through the gonio prism, the TM can appear a little bit more flat, even though it's actually curved. So be ready for that. So angle anatomy, you know, we didn't just learn everything there is to learn in this lecture or in other lectures on CyberSight. CyberSight's an excellent resource. I would encourage you all to keep watching all these MIGS lectures. You have to go to many sources. The companies are out there to support you. There are multiple lectures, meetings. You can see surgical implantation videos by experts on YouTube and iTube, all the latest devices that are being tested and trialed. You can see how these experts are putting them in, and they'll show you their tips and tricks. Two excellent websites you all have to go to, gonioscopy.org and anglesurgery.org. There's just no substitute for those websites. You want to put the gonio lens on your patients in clinics to see the angle structures. Get familiar with the angle. There is going to be significant variation in anatomy and pigmentation. And here's a huge tip. Practice intraoperative gonioscopy on routine cataract patients. You don't have to have a model to practice all this. You have patients right there. You're not going to do any harm at the end of your case. Put them into head tilt, adjust the microscope. We're going to show you all that. Get the view, put the prism on, go out there with a hook, with a viscoelastic cannula, go out there and identify the landmarks. Okay, so polling question. My understanding of angle anatomy is, it's the same question. Just let's see if we have any difference from what we did a minute ago. Excellent, just okay. Nobody said what's the angle before, so I think we're good there. Okay, well, we went from 50 to 80%, so that's good. I'm happy that this is being useful. There's a lot of work to do, though, outside of these lectures. Okay, back to key steps to prepare for MIGS. You have to understand how to achieve optimal visualization of the angle. This is so important to get the view and maintain the view. So let's go through that. Visualizing the angle requires a gonio prism. You typically have never used it before. You've used your gonio lens in the clinic, a tear film lens or a gonio gel lens, but not a surgical gonio prism. Get one. Start putting it on your patients. You need to have additional viscoelastic ready. Okay, you have to fill the eye, pressurize the eye. I like to use a thicker visco, like a Helon GV. We'll talk about that later. You need viscoelastic on top of the eye to couple the prism. Patient positioning is so important. Your scope has to be able to turn, but your patient has to be able to turn. They have to have the flexibility in their head and neck, and they have to be stable. Don't have your first patients have somebody that has really bad neck problems or has nystagmus or something like that. We want a nice, stable platform. The surgeon positioning is also important. You're going to be in a different ergonomic position. Your chair height has to change. The scope is going to tilt, so the oculars have to be tilted back up. Either an assistant has to do that for you, or you have to be able to have sterile handpieces on those where you can reach down and adjust it yourself. Your chair height's going to be able to change. So you need to have a chair that can easily raise and lower. Your approach angles, so where you sit, you might want to adjust your positioning away from your incision. to get a better position there. You have to have adequate magnification with your scope. It's helpful to increase illumination so you can focus in on the structures. And the key is to maintain the view throughout the procedure. And we'll talk about that as well. So again, these visualization skills are key to success. It's imperative, absolutely imperative to practice this intraoperative gonioscopy on standard cataract patients in advance. Let's take a look here. This is a nice video done by Jason Jones showing intraoperative gonioscopy. He's got the prism on, and watch him focus in now. He's going to focus in, and you can even zoom in more. There we go. You know, fill that view, the prism, fill your view. Look at that beacon of blood in Schlemm's canal. There's no question where your anatomy is here. We've got scleral spur and anatomy. Sorry, let's go back to that and just, there's a bunch more there. I just timed out of it. So let's watch a few more of these. Focusing in, getting zoomed in. That was interesting. Did you see a little bit of blood that came up on the, you can see it there. You can see the blood on the surface of the cornea. So make sure you've got your field cleared of blood, and then get the viscoelastic on there. Here's another view. Look at where the position of the prism is. It's not way back on the eye. It's almost more forward. As you tilt forward, you get a better view. And look at how he's able to hold and maintain that view. Let's jump ahead here a little bit. Here's another one. Fantastic view. The concave iris. It's opened up by the viscoelastic. No question where that anatomy is. The scleral spur stands out. The blood in Schlemm's canal stands out. Very easy to identify. He's maintaining that view very nicely. Things get out of the focus a little bit. You can see how putting some pressure, moving around, you can distort your view. So you've got to learn to float that prism on there. Again, another view. Look at how easily it stands up. There's no reason not to have a good view and practice on that. Okay, let's move on. So here's with the model. You can just put viscoelastic on the top, add visco to the cornea, and you can practice with sliding your prism around. The key is a light touch. So with these models, you're not going to be able to indent the cornea and get the folds. It's going to be easier to maintain your view, but you want to learn that light touch. And one of the biggest tips I can give you is, they always say, think about, don't push down, you know, have a light touch, float. But I almost like to say, pull up on that gonio prism. Not so much that you're going to uncouple it, but just enough to really open up the cornea and not have any folds. Here they are demonstrating visualization. So this is a model that the glaucos used to use to help demonstrate prism and the view, but they weren't able to implant the stent in there. So we've worked with them to develop something where we actually can implant into a model now. Okay, let's move on to another couple videos. Here's other ways you can practice. So this is showing that you want to have the correct angle on the prism. You don't want to be too far tilted forward or back. If anything, tilt forward a little bit. You can practice, take a mark, take a word like this with viscoelastic gel or just in water, and you can see what happens to your view. As you tilt too far back, you're going to distort your view. Imagine if you're trying to find the angle structures. It's not going to happen. So if you rotate that prism more forward like that, you're going to open up your view. You're really going to get a nice clear view of the anatomy. Let's do a couple more here. This is just showing the design of this particular prism. Notice what's nice about this is it's a very wide angle view, and it has that curvature, that cutout for your incision. So you can more easily get into your incision, but look how wide it is. There's all sorts of different gonio prisms out there. Try different ones. Find out what's best in your hands. Find out what you need to help your patients and help yourself get that view. But it's a tremendously wide view there, and you're not hitting the device as you go through the incision. And one last one. So this is another attachment that they have. If you need to stabilize the patient, they have a device now you can clip onto the prism so you can actually rotate the eye. Or let's say the patient's having trouble looking in a certain direction, or they're blocked and they can't move their eye where you want them to. You can actually use this clip and rotate and stabilize the eye while you're doing your implant or whatever procedure it is that you're doing. Okay, so pearls for optimal visualization. Better visualization is greater chance of a successful MIGS procedure. That's just the bottom line. If you don't have a good view, nothing's going to happen properly there. The surgeon and the assistants need to know how to turn the scope and the patient's head to get the best view. Don't let your first MIGS case be the first time you do this. Practice it on your routine cataract patients. We can't emphasize that enough. You're going to have to release the tape on your patient's head if the patient's taped down. I like to have them cut both sides of the tape, but obviously you just have to cut the side towards you because you're turning the head away from you. Consider placing a pillow under the patient's shoulder to help support them if that's helpful for them. You definitely want to increase your MAG. Focus on the target implantation site. I actually like to try to focus before I even get the prism on there. I try to get in rough focus on the limbus, on the distal limbus. And that way I know that I'm pretty close to being in focus on the TM so that when I get the prism on, I don't have to do a lot of focus at that point. Ensure the microscope can deliver adequate illumination. You can use a miotic agent to bring the pupil down. I don't think it's really necessary, but it's certainly not harmful in your first cases. You definitely want to use a nice cohesive viscoelastic. I like Helon GV for this. It's just really solid. It gives you a nice fill of the anterior chamber. It opens up the angle and it really pressurizes the eye. So if you do have a little bit heavier feel or touch on the cornea, you're not going to get those corneal folds as easily. The things that are going to drop your view are if you're distorting your incision and you're losing viscoelastic, and if you're pressing on the cornea, you're going to get those folds, and that's going to kill your view. Both of those things have to be happening. You have to float in the incision, and you have to float on top of that cornea. And again, I like that technique of actively thinking of pulling up slightly with the prism to not be pushing down. You want to add a heavy dollop of visco on the cornea, and then have this light touch like we've been talking about. If you distort the wound or the cornea, you're going to lose your view. And again, don't proceed with any MIGS procedure until visualization is achieved. So preparing for successful intraoperative gonioscopy, you've heard me say it a few times, I'll say it again. Practice intraoperative gonioscopy on your patients that are having standard cataract surgery. Practice turning your patient's head and tilting the scope, getting light pressure. Practice getting comfortable with a different body position. You're going to be further from the patient. When you turn that patient head and you tilt the scope back towards you, now all of a sudden you've moved back away. So your arms are going to be much more extended. Your elbows are going to be in a different position. Your hands are going to be resting differently. Practice getting comfortable. Then, of course, practice locating and visualizing the anatomical landmarks, and practice introducing another instrument like a Sinskey hook. You don't have to have the MIGS device necessarily to practice. Just take a Sinskey hook or take the viscoelastic cannula. Go out there, see your anatomy, touch the meshwork, touch the spur. You can do that all out safely. So here we talk about patient and scope positioning. The patient head, you don't want to try to get all the change in either the patient head or the scope. Do half and half. So rotate the patient head 35 degrees and tilt the scope about 35 degrees. Let's take a look at this little video here of that happening. So here we are, the patient, they just finished the cataract portion. An assistant is tilting the scope. I like to have a sterile handle on there where I can do that myself because I know exactly where I want to put it. I don't have to rely on somebody. As the scope tilts down, look at where the oculars are going. So the oculars have to be tilted back up. So let's bring those oculars back up into line. And then once you do that, you're still tilted a lot further down. So you're going to have to adjust your chair height position. So you don't have a chair that you can drop easily. Now we need to adjust the patient's head. And so here we are. The tape's been broken. We're going to rotate that patient's head, pretty maximally over there to about 35 degrees. Again, you're going to have to adjust your chair height and the bed height, adjust the oculars. It's so much easier if you have sterility there that you can do it yourself and adjust the patient position to optimize your approach angle. This is just showing, just like with our phaco incision, you don't necessarily want to be directly in line with your phaco incision. Same with MIGS. When you're using a device, give yourself that positional advantage. Be off to the side 15 degrees so that you're not jamming your wrist. You want to be very comfortable and relaxed and no tension or stress when you're doing these devices. It takes a very steady, good positioning. Okay, let's move on now to these next 3 points. Understand the device and injector, including features and benefits. Understand the implantation technique and know the surgical and procedural checks and contingency plans. So if you're working with a MIGS device, I don't care what device or what technique it is, all of this information can be obtained through the company. They're there. They want to support you. If you don't have local representation, you can get it online through websites, through iTube and YouTube, through lectures. But all of this stuff, all these next 3 points come from the manufacturers. They're going to have their knowledge base out there for you to tap into and be able to teach you this stuff. So for example, with Glaukos, their newest device, the iStent inject, it's a very high-tech device. It's tiny. You can't really visualize it all that well. You need to know what's going on. You need to understand the size and where it's going. You've got your conical head here. You've got your side flow outlets. There are 4 of them, the neck. You've got your flange back here and the central inlet. So basically, we're embedding this thorax in the trabecular meshwork. It's made of titanium. It's heparin coated. It's biocompatible. All this information you need to understand if you're going to be working with this device. You also have to be very familiar with the injector. Just like if you're evaluating a new IOL, it's not enough to evaluate the lens. You also have to evaluate the injector and know how that works with your patient safely to get that lens in the eye. Same thing here. With a MIGS procedure, it's oftentimes there may be a device or an implant, and there's going to be an injector. So evaluate, know the components, know where the buttons are that you have to retract or push. Know that you have a microinsertion sleeve, and then you have a microinsertion tube. Here are the stents lined up, your trocar, the V slot. Understand that you have to keep that trocar very well centered in order to deliver these stents into the proper position. If this is bent off to the side, these are going to hang up, they're going to hit the insertion tube. The company will teach you all this. They're going to have their surgical scenario matrix. When you implant the first implant, you dimple, and then the second one, well, what happens if you don't get the first one? If it underimplants, what do? You do flush, you do a double stack. They're going to have this whole flow sheet to teach you. We're not going to go into that all now, but the point is rely on the company. They've been through this. They know how to teach this really well. So let's talk about another MIGS technique with LX, the iTrack surgical system. This is ABIC, ab internal canaloplasty. Again, very high tech. You've got a little light box here. You've got this viscoelastic that you're going to inject on the way out. And this is the key, this catheter. The technology here is incredible. They're going to show you what's in their technology. So this tiny little catheter, you wouldn't believe how small this catheter is. It has this polymer shaft and this distal atraumatic tip. It's like a bulbar tip that helps you pass this catheter into Schlemm's canal and around the canal 360 degrees. You've got an optical fiber for light transmission. You can get that blinking light to see it safely. You know that you're safely passing around the canal. In this tiny little catheter, you have a guide wire, a catheter support wire to give it some stability, and you have an lumen. This is incredible. When you see how small this catheter is, to have all of this technology in this tiny little catheter, this lumen is where your viscoelastic comes down. So you catheterize the cannula 360 degrees, and on the way out, you're injecting viscoelastic, and you're maintaining the anatomy, you're blowing open the canal, you're blowing open the collector channels, and you're improving the outflow through the conventional system. These companies, they work with the key opinion leaders, the leaders in the field. They do research, they have anatomy, they can teach you. You're gonna see material and information like here's our Schlemm's canal and here's the episcleral veins, stuff like this that you may never really understand or see otherwise. They're going to show you not only anatomy but pathophysiology, what's happening in glaucoma, things like tissue herniation into the collector channels. They're going to explain to you why their technology is why it works, why they believe that their technology can help your patients, how you're going to catheterize the canals, you're going to break through these herniations and open up the channel. Okay, so let's get into some of the fun stuff. And the last thing under key steps to prepare for MIGS is practice, practice, practice. That is certainly a mantra, including with models. We know we can practice on patients. We know how now, but we also can practice with models when they're available. Let's do another quick polling question here. Before my first MIGS surgery, number one, I practiced with models, I practiced on animal eyes, I practiced with human eyes, or I did not practice on anything prior to my first cases. I guess we're assuming that you guys have done some MIGS cases. So let's see if you guys have practiced. So 36% practice with models. That is fantastic. 45% practiced on animal eyes, 0% practiced on human cadaver eyes, and 18% did not practice on anything. So not practicing on anything, I think, is, that's not where we want to be. We want to practice at least on our own cataract patients to get the positioning and get that. And then you can practice on a device, even if it's just holding it in the microscope, outside, getting a sample of it and practicing. Human cadaver eyes, when I was trained on MIGS, initially by Glaukos for the initial iStent, they had corneal rim tissue, so it was human cadaveric tissue. So there were some advantages. You could implant into the tissue, but it wasn't a realistic experience of getting the view and maintaining the view and all that goes along with that patient tilt and all that was new in MIGS and the positioning for me. It's fantastic that people have had access to models. Animal eyes obviously have their limitations. We're going to talk about some of that. Let's see if we can move forward here. Okay, so in terms of practice, we've been over this and over this. You can practice on patients having standard cataract surgery. You're not going to practice with the actual device, but you can practice the other 80%, which is getting the view and maintaining the view. With human or animal eyes, there's obviously limitations there. There's cost, there's availability, there's sterility, safety issues. You can't take these into your own OR, and quite frankly, they're really not that pleasant. And pig eyes, they don't even have a canal or Schlem. There was a nice study that showed that the canal or Schlem in certain pigs is absent. So model eyes, I'm not saying they replace everything, but they have a very good role. They can be used inside or outside of the OR, and they allow to practice the entire procedure. They really are a nice adjunct to this. So with models for MIGS, the use of model eyes, you can practice head tilt and hand positioning, visualization of the angle using a prism, and working with the MIGS devices to simulate the entire surgical procedure. We found that to be extremely helpful for surgeons prior to actual surgery. This has been validated by feedback from many experienced and novice surgeons, as well as the companies that we work with utilizing the models. These models provide a training platform to practice in a non-stressful setting where the surgeon can make adjustments and gain confidence prior to their initial cases. We're not trying to be exactly tissue. Tissue has its limitations. It's hard to obtain and all that. But these models, they're not going to be the perfect tissue representation, but they're going to provide a great training platform to learn all the steps, and there are no penalties for mistakes. You can practice and practice and practice and get comfortable. There are various eye models to practice different MIGS procedures. Again, there are limitations. It's not actual tissue. We're not going to necessarily create the corneal folds. It is going to be easier to maintain the view, but I think that's valuable. We want it to be a little bit easier in the practice setting to get confidence going into the surgery. But you can't just jump in without the background and understanding. Not only do you need access to the MIGS devices, but also the models, and you can turn to industry for this. These companies, they want to promote their devices. They want to educate you. They want to support you. And they will get samples to you, they will train you, they will get the models, they have the models. You don't need to come to us and purchase models from us, go to the companies. It's mostly available through the device companies, through dry labs at the various meetings. There are dry and wet labs set up to practice and train and learn these techniques. All MIGS techniques can be performed on models. Again, may not be exact tissue feel and performance, but it acts as a platform. You can get a feel for the device and the inserter inside an eye and within the confines of an incision under gonioscopic visualization. And that's really the advantage here, is you can see what it's like to be in that incision, trying to get the view, having both hands work together and your foot, adjusting the microscope, getting your ergonomics down. This is particularly important for your first MIGS procedures. And you can do it over and over again and get muscle memory. So again, contact your local reps, reach out to the companies, and have your rep there with you during initial cases, and even for some later cases for more advanced tips. As you get to a certain level, they're going to come in and they're going to start teaching you more of the subtleties of hand positioning and what to do when. So you can retry things again on the models, but lean on that rep for support whenever you can. One of the keys with models for MIGS and just MIGS in general is you've got to have a tilting stand and you've got to have a tilting scope. So in your OR, your scope has to tilt and you've got to have a stand to set up that model that tilts. So here's an example of our Simuli MIGS kit. It's very small and compact. And when we set it up, it takes just a minute to set up and take down. You have a nice tilting angle here. We can get at least 30, 35 degrees. Our base unit sits on here and the eyes will attach onto that. And it goes down compactly to fold away very nicely and travel. So when we worked with Glaukos, they already had this stand available because they were using it for visualization with their other model. When we started working with them, they wanted to continue using this stand that they liked. It allows hand positioning as well. Ours does too, but they were committed to their device. So we just created an adapter that our eye can go onto into this Glaukos stand. So we're going to get into the models here and showing some videos. But if you want to be like Ike, you got to use models. And let's see what Ike has to say about models and MIGS.
Take the pressure off.
Well, that's exactly right. Ike is fantastic about reducing pressure for his patients, and models can help reduce the pressure for you as you go into your first MIGS cases. So let's take a look here. Alcon CyPass, we know the device has been recalled, but just let's look at this video. You can see how it's helpful. We're going to put the viscoelastic on top, couple the prism, get our view. You can see the TM and the scleral spur. In this case, we're going suprachoroidal. So we're going to disinsert the ciliary body there, slide into that suprachoroidal space, release the device, and then tap it into position, all under gonioscopic view through the incision. Let's look at another one now. Here's our friends with New World Medical. They have the Cahook dual blade from Dr. Malik Cahook, and you've seen his lecture on here probably last week, I believe. So let's take a look at what we did for them. Again, viscoelastic on. This is a different model. This meshwork we can actually excise, so you can practice different techniques of initiating, incising the meshwork and then removing it, whichever technique or pattern you're comfortable with, wherever you want to start and finish. You can actually remove the tissue. Get a feel for that blade sliding in there, being oar-locked in the incision and rotating through the canal. Our friends over at LX have the eye track device that we've talked about. You can see the catheter here inside the eye, the blinking light as it goes around through the canal. Look at this nice, elegant setup. This is not a big OR setup. This can be done, a lot of places. They have this type of support. They've got this, great microscope with tilting capabilities. Here's their illumination box. Here's the stand with the eye on it. They've got a camera on here and a screen so that the trainer can help support and see what's going on, and minimal equipment setup required. You've got the eye under here and you can see what's happening there. You can take this same type of stuff and put it in the showroom. So you're going to go to the meetings, you're going to see this little dry lab setups at the show. Here's a surgeon, with the setup, and this is in the simuli. He's got his prism on here. He's got the MST forceps that they recommend. Here's the blinking light. He's just starting to put it into the Schlemm's canal through the goniotomy. This is a great video. This comes to us courtesy of Dr. David Lubeck. He's the LX Chief Medical Officer. It's a few minutes long, but it's well worth watching. So let's take a look at this video. This is comparing the difference between the model and the actual human surgery. So here we are going through the incision, filling the model. We have pre-placed side port incisions because the catheter is so delicate to try not to bend it. So we pre-place those in the eye, taping the catheter down just like you would do next to the patient's head, getting everything positioned. And now here we are in the actual eye, filling the eye with viscoelastic to deepen the angle, and similarly taping it right next to there. And the positioning of that is important because we want the correct angle. Here he's making the paracentesis at the correct angle. We've already made the paracentesis, so we're just going to, he's going to insert the catheter, and you want to lay it right up there by where your goniotomy is going to be. Now putting the viscoelastic on the eye so we can couple up with the prism, get a nice view. In this eye we have a pre-made goniotomy, which is easily recognizable there because we want to be able to use those eyes over and over again. We didn't want that consumable element in there. And also for speed of use in training, we want people to really be able to get into the heart of this, which is passing the catheter. So getting our view, here he's going to make a goniotomy. This is a fantastic view. Watch him take down the anterior part of trabecular meshwork and open it up, and you can actually see the back wall of Schlemm's canal there. Fantastic. So we've got a goniotomy there. Now we're going to pass gradually with the MST forceps and very atraumatically pass it into the canal. You can see the light passing, and as he continues, you're going to see that light. It can be either blinking or solid. You're going to see it pass around. You'll be able to visualize this on the outside there. It's blinking, coming around the limbus, and then we've cut forward, fast forwarded here, and now it's coming in through the last 360 degrees and into the angle again there. And now you know you're 360 degrees. Well, here it is on the human patient, passing it into the otomy there, carefully, atraumatically passing it around the canal. We're going to see the blinking light come around. We know we're safely in the canal. That blinking light is our beacon. We know we're safely in the canal. It's passing without resistance. It's passed around there. And here it comes into the eye again. We know we've gone 360 degrees. And now pulling it back. And on the way out, this is where viscoelastic is getting injected. So we've broken open those herniations on the way forward, on the way back. We're injecting viscoelastic. You can see the light passing back around the canal. In the model, we don't necessarily need to inject viscoelastic, but that can be simulated. And here we are pulling it back out. And we'll see the same thing in a moment of safely, atraumatically removing the catheter from the eye to complete the procedure, which is here. He puts a hook in, he supports it so there's no extra pressure on the meshwork. And here we are pulling it out. You can see the blinking light going around. It's passing safely and smoothly. Viscoelastic's being injected in and opening up those collector channels. Fantastic video showing the back and forth between the human eye and the simuli. Really appreciate this work by Dr. Lubeck. Okay, let's look at another one. Here's the Glaucos. This is the model we just did for the iStent inject. Going in, filling with viscoelastic. They wanted the clock hours on there because part of it is you've got to be 2 clock hours apart, ideally. So we've got our view, retracting the protection sleeve, going over, hitting the button, and implanting the iStent inject. They're very small. It might be hard to see, but bam, there they go. We're actually able to implant the device, get a feel for that button, pressing the button. Let's do that again, just kind of run that again. So again, the clock hour marks, but basically, you know, you're in such a small space under view, and there's going to be a feel to that button. And so when you press the button, there's some resistance. You want to have your hand positioned exactly where it needs to be. You're going to dimple a little bit so that you can implant the stent. Not too much, not too little. Try to get a couple clock hours apart and deliver that device. Here's the setup. This is my OR on the left-hand side. We set this up just to take this picture. We've got the Glaucoma stand with our eye on it. Here's some injectors for the iStent inject, viscoelastic, and a prism. That's all we need. It's pretty simple. We've got a tilting scope. We've got video capability so the techs can see it, other people can see what's going on, and you can see the eye up there. You can do this in your own OR. It's not animal tissue. Here is another setup. This looks like more of a wet lab setup that Glaucos did. You can't see it too well probably, but this eye, the simuli here, has multiple devices implanted in it. You can practice over and over again. Just keep getting the feel of what it's like to deliver, dimpling the meshwork, implanting. That's what you need to do. So our motto, practice safe MIGS with supermodels. We've got our KDB model to excise the meshwork. We've got the iTrack model for LX to help catheterize and go 360 degrees around the Schlemm's canal. And we've got the iStent inject model to deliver that device into the meshwork and get it in there in the proper position. You just got to practice. I can't overemphasize it. There's so much you can do now to practice before your first cases. With MIGS, you've got to keep calm. You can't have a shaking hand. You can't have nerves. You've got to practice before you go into your cases. And if you practice, you can keep calm. You can get that view. You can have a lot of success right from the beginning. And you're going to find MIGS to be a lot more enjoyable procedure, and you're going to find nice outcomes for your patients. So I want to give special thanks to our industry partners that we work with, New World Medical with the Cahoog dual blade, LX with the iTrack for the ABIC ab-internal canaloplasty procedure, and Glaucos for the iStent inject. We've partnered with these companies to develop the models specifically to their needs to get the training to you guys that you want. Our whole motto is with the simuli models. Our motto is training surgeons, supporting industry, and improving outcomes. And I believe we're having an impact in ophthalmology and the ophthalmic community to make things better and safer for our patients. And of course, I want to give special thanks to Orbis and CyberSight for allowing us this opportunity to share with you guys. This is a production run of our models that we did. Just thought it was a nice picture to kind of show the view of all the models there. So thank you for your time and for joining us. If you want more information about the models and what we do, please visit our website at simuli.com. Thank you very much. Okay, so are there any particular model eyes, heads to use? Are there any low-cost options available? So particular model eyes, obviously what I know mostly about is our line, which is the Stimuli models. There are certainly other models out there. I don't know exactly which companies or which devices they're working with, but we work with those three major companies. Heads to use, we have our stand that works with our eyes. Our eyes work with a suction cup base, so any flat, smooth surface can be used, or heads can be modified. We've even used our eyes in styrofoam heads. We cut out an area for the orbit and put a little cap in there. So there's ways to modify these things for sure. Are there any low-cost options available? The lowest cost option is to reach out to the companies. If they're all in your area, if you have access to these devices, reach out to the company and say, hey, I want to get trained, I want to practice. And they will come in, they'll bring the device. You have to have the device or the sample, samples, and they will generally bring their training devices, whether it's our models or something else, they're going to bring that in. So that's about as low cost as you can get. Hi, I just finished my residency. Are those devices cost effective? I think they're very cost effective. Again, if you reach out to the companies, if you go to the meetings, you don't have to pay anything for this training. The companies want to train you. They want to find you. They want to promote their procedures. They're effective. They're going to work with you. How soon will this type of procedure be available in Africa? That I can't speak to. You'd have to reach out to our friends at Orbis. I don't know where things are with that, but certainly some procedures lend themselves more to an area like Africa than others. Some devices are less involved from a technical standpoint. For example, I think a Cahook dual blade is going to be more readily available than something that requires a lot more setup and materials. How do you stimulate intraoperative blood reflux? Is it possible? It's possible. We've done it. It's not really necessary. So it's, that's not something that we found that was really important. It adds a lot of setup, a lot of cost to the models, and I don't think adds really much value. In developing countries, what is the best approach to learn cataract surgery? To learn cataract surgery, wow. Learn from your mentors, learn from the people around you. I mean, the cataract surgery techniques there are so different than here. With small incision cataract surgery, there are people that are really out there driving that field and teaching it. But I mean, there's videos online of and all the techniques. So you got to reach out for those. The indication of MIGS, that's a bit more than what we can cover right here. I mean, there was another really good lecture on CyberSight, so look for that about the indications of MIGS. All that stuff is covered. Go to CyberSight. It's such a valuable resource here that you guys have access to. What is the benefits of the patient? Well, MIGS, it's microinvasive. It's low risk. It's it's easy to do. There's not a lot of follow-up that's required. It's just low impact for the patient. No blood management. Huge benefits for the patient of MIGS. And which MIGS procedure is the most effective in the long run? Wow, that's a big question. That's very, there's a lot there. It really depends on the patient, what you're comfortable with. I guess the best MIGS procedure is the one you're the most comfortable with, but get comfortable with multiple procedures. If you want to, treat your patients the best, figure out what's best, and that's still being determined. The key opinion leaders, the experts in the field, they're helping us understand when should we turn to what procedure. Should we be targeting, the mesh work, the outflow? Should we be bypassing the conventional system? Which patients benefit from which procedures? Do we need to go to a more aggressive procedure, like in a more advanced glaucoma patient? Maybe we need to still have that bleb or something like a Zen that helps us, with a more controlled bleb. It really just depends on so many factors of where the patient is with their disease and where the surgeon is with their skill level. So I hope that provides good answers to those questions. Low-cost model for Nepal. Again, I don't know what we're talking about when we say low cost, but again, if you can reach out to the companies, you're going to have low-cost options for free as the companies have training set up. So I don't know how the devices are accessed there, but all I know is the models that we're doing. Let's see, thank you. Can you talk about rejection in relation to these devices in human? That's a good question. These devices, if we're talking about the implants, the things that we leave behind in the eyes, I've never seen or heard of cases of rejection per se. Now, there can be things like fibrosis. There can be problems like we saw with the CyPass, where there was some endothelial cell damage, and it's very likely that that was positioning related if surgeons weren't getting it tapped down. I mean, it depends on how you compare those things as well. But to say rejection, these are not, graft materials. These are not cadaveric materials, or these are synthetic materials, and they've been tested and designed. I have not heard personally about rejection like an immune response to these devices. And then we have, what is the cost of the models? The cost of the models varies considerably depending on if there's a consumable element to a reusable element, and they're not cheap, but they're effective, and they can range in price from $40 to a couple $100. And of course, you have the kits to set things up and the stands, and that's why I say hopefully you don't have to bear that cost yourself. You can reach out and partner with the industry. They want to find you. And so if there's a given region or a hospital or a center that wants to bring a certain MIGS device in, contact the company and see what they can do, because I bet they're looking for you too. So I think that's all of our questions that I see.
Yep, so that looks like all of the questions. There's actually one more, it looks like.
Is it reusable? Certain of them are. For the ones where there's a consumable element, like with our model for the Cahook dual blade, we're excising the meshwork. So, you can rotate the eye and do, 3 or 4 treatments, but then it gets consumed. For our model with the Glaukos iStent inject, again, that meshwork is getting consumed, but you can implant a lot of stents in there. The meshwork runs 360 degrees around the eye, so you can rotate the eye, make a new incision, put some more viscoelastic in, and keep implanting as long as you have those devices. For our iTrack model, that model is pretty robust. It is reusable. You can catheterize it, get the cannula, the catheter around the Schlemm's canal, pull it out, do it again and again. The catheter is very delicate. You want to have a nice light touch, just as within surgery. If you have that light touch and you develop that skill, you can reuse that model multiple times. You might need a couple catheters to get to that point because you'll find the catheter is delicate. But that's important, is to understand how delicate it is, how you have to handle it, how you have to grasp it carefully, because that's what you want to do when you're in actual surgery. How effective are these devices in lowering IOP? Well, they are quite effective. They've been studied. They're, again, going back to the beginning of the talk where we said, MIGS devices, part of MIGS is they're safer, they're easier to use, they're easier to manage, but they're not as efficacious as traditional glaucoma surgery like tubes and shunts and trabs. But they are effective, and you're going to find out in your hands what's the most effective for a given patient. I think the rest of that question is a bit beyond the scope of what we can go into right now.